Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein.
Hi, everybody. Welcome to our program this evening. Thank you very much for joining in. We are together to have a Medscape Global Oncology program entitled Endocrine Therapies in ER-positive, HER2-negative metastatic breast cancer, understanding their benefits and limitations to optimize treatment selection for our patients. A very, very important topic, of course. I'm Joyce O'Shaughnessy, breast medical oncologist at Baylor University Medical Center, Texas Oncology, and the Sarah Cannon Research Institute in Dallas, Texas. It's a great pleasure to be joined by excellent faculty and friend, Aditya Bardia, who is professor of medicine at UCLA, directs the breast cancer program, is also the assistant chief of translational research in the Division of Medical Oncology, and also directs the translational research integration at UCLA. So good to be here with you, Aditya, and discuss these evolving topics, which I know you've been very, very involved in so many of these trials. So this program, we're going to focus on endocrine therapy in the metastatic setting, resistance mechanisms to endocrine therapy, what kind of sequence should we consider in metastatic breast cancer, the biology of some of the key resistance mechanisms, including ESR1 mutations, oral SERDs, where are we, some of the key data, the key trials, some of the key differences between the options, and future directions. The data are coming very quickly, and our landscape is really changing. So we're going to start by looking at current endocrine therapies for the HR-positive, HER2-negative metastatic breast cancer. This is our key target, of course, in this disease, and we're well familiar. If we start here with estrogen, leading to homodimerization of the estrogen receptor, which goes into the nucleus, and it binds to coactivators and drives, thousands and thousands of gene transcription to drive the cell and keep it alive. We're very familiar with tamoxifen, the SERM, which goes into the nucleus and attracts co-repressors rather than coactivators and turns off gene transcription. And we're very familiar with the SERDs because fulvestrant has long been a SERD. Now we have elacestrant, which basically binds to the estrogen receptor and leads to the destruction of the estrogen receptor, so it doesn't dimerize and it doesn't get into the nucleus. And now we have the PROTAC, and we'll talk about the new data on our very first PROTAC, which basically also leads to the proteasomal degradation of the estrogen receptor by bringing the estrogen receptor in close contact with this E3 ubiquitin ligase, which leads to the ubiquination of the estrogen receptor, which drags it off into the proteasome for destruction. And then we have the CERANs, which basically bind to the estrogen receptor. It gets into the nucleus, but it completely attracts and binds to co-repressors. It blocks both AF1 and AF2, which are co-activation, co-repressor sites, and it blocks both of them and shuts down transcription And then the circas are interesting. They stop calcium channel flux and lead to a proteasomal, a protein degradation, a misfolded protein, which then really cannot lead to transcriptional activation. So we have a number of ways you can see here to actually inhibit that estrogen receptor. However, as you'll see, the ones that we really have the main data on, we have our SERDs and we have PROTAC. Well, of course, we have fulvestrant back in 2010 for metastatic breast cancer. And then we have Rolamis in 2012. And then we got the CDK4/6 inhibitors in 2015 to 17. Then we had alpelisib in 2019, capivasertib in 2023 to block AKT. We had elacestrant, the oral SERD, and most recently, the PI3 kinase inhibitor, inavolisib in 2024. So that's our current armamentarium, but things are also expanding rapidly as we get new agents to hopefully better inhibit the estrogen receptor, particularly in the context of resistance to a prior endocrine therapy. So just a couple of words about the big picture about how we treat ER-positive breast cancer. As you well know, in the first-line setting, patients require a CDK4/6 inhibitor, either with an aromatase inhibitor, if it's de novo metastatic, or they've been off their adjuvant AI for at least a year. If they recur on their adjuvant AI or within a year of finishing their adjuvant AI, then they get fulvestrant with their CDK4/6 inhibitor. And when their disease progresses, that's the critical time to check ctDNA for molecular alterations that will be targetable. There's only one caveat on this, which is that if a patient recurs on her adjuvant AI or within a year of finishing her adjuvant AI, we actually got to know before she starts her CDK4/6 inhibitor and fulvestrant, we got to know if she has a PIK3CA mutation, because if she does, then and if her hemoglobin A1C is less than 6%, she's a fabulous candidate for the triplet of inavolisib, palbociclib, and fulvestrant. Nice big survival advantage with that, and a huge improvement in PFS for that particular patient. We got to know who's PIK3CA mutant at the time of that first presentation of metastatic disease. Otherwise, patients get their endocrine therapy and CDK, then they progress, and now we go looking for an ESR1 mutation, AKT, PTEN, and PIK3CA. Those are the main ones we go looking for, because in the second line setting, we want to continue endocrine therapy with a targeted agent, or if it's an ESR1 mutation, we want to come in with an oral SERD, elacestrant, if the patient's appropriate for that, in the second line setting. So that's the most important point, to look for these alterations. Then the patient gets treated with targeted therapy and another endocrine agent, or with elacestrant alone. And then at the time of progression, we want to repeat the ctDNA testing, because if we haven't found a target yet, we still want to keep looking with every progression. As I'll show you with ESR1 mutations, for example, they can really come out at any time in the metastatic journey under the selective pressure of endocrine therapy. So, and we can also find acquired mutations in AKT, PTEN, PI3 kinase, and of course the ESR1 mutations are basically all acquired. So we have to basically keep looking for these alterations all across the spectrum with each progression of disease, because we want to keep the endocrine therapy going for as long as we possibly can before going to cytotoxic therapy, provided the patient's performance status and organ function remains good. So that's the big picture. And now let's look at some of the major mechanisms of resistance, because unfortunately, our patients' breast cancers do develop resistance to that first line endocrine therapy and CDK4/6 inhibitor therapy. And one of the key mechanisms of resistance is activation, mutations, constitutive signaling through the PI3 kinase pathway, either with a PI3 kinase mutation, AKT activating mutation, loss of PTEN, and which can lead to activation of these important proteins, as well as mTOR. And as you know, we have multiple therapies to inhibit this key resistance pathway for HR-positive, HER2-negative breast cancer. Now, PIK3CA mutations, we'll find them 40% of the time. You can also find them in the primary breast cancer. PTEN mutations or their loss of function alterations, you can find them in the primary breast cancer, but they can also, they're more commonly acquired in the metastatic setting. AKT mutations as well tend to be more in the primary breast cancer, but they can also be acquired. You can see that PTEN loss of function mutations and AKT mutations about 5% of breast cancers, HR positive breast cancers, but it's critical we don't miss them because now we've got capivasertib. We actually have a really effective medication to inhibit growth and survival of these cells if we find breast cancers that have developed resistance to endocrine therapy because of PTEN loss or AKT mutation. We didn't have anything heretofore. The ctDNA testing has gotten good enough, but now it's actually getting to be pretty accurate to be able to find even loss of function mutations. And so, in addition to the activation of the growth factor pathways that we see in the middle there, PI3 kinase, you can also get mutations in receptor tyrosine kinases, such as activating mutations in HER2. So that the gene's not amplified, it's not HER2 positive, but you get activating mutations in HER2. Very well worth knowing about because our tyrosine kinase inhibitors such as neratinib and tucatinib can inhibit those activating mutations. And also TDXD is very, very active against cancers that have HER2 mutations. So again, another thing we want to look at, and those are acquired in the metastatic setting, particularly enriched in invasive lobular cancers. But then over on the right, another very, very important resistance mechanism to endocrine therapy, particularly aromatase inhibitor therapy, and particularly aromatase inhibitors with CDK4/6 inhibitors, is a mutation in the estrogen receptor that renders the estrogen receptor constitutively active. It doesn't need any estrogen, it doesn't need a ligand. It just dimerizes, goes into that nucleus, and drives transcription without a ligand. And these are very, very common. Up to 50% of patients who have been exposed, particularly in the metastatic setting, to an aromatase inhibitor over time with endocrine therapy, up to 50% will develop an ESR1 mutation. That cancer is still endocrine driven. It's ER driven disease. It's just it's an estrogen receptor where our aromatase inhibitors really don't work at all. Tamoxifen doesn't work, and fulvestrant only works very much partially. So our standard therapies really don't work well, if at all, against these mutations. But thankfully, we've got the oral SERDs, and that's really why we have them, is because of this ESR1 mutant group of patients. But they're very, very common, but they're acquired. They basically emerge over a time. Almost all of the ESR1 mutations are in the ligand binding domain where the estrogen binds. And so it changes conformation and becomes constitutively active, does not even need the ER, is always switched on. And the wild type estrogen receptor binds beautifully to estrogen, tamoxifen, fulvestrant, but the mutated ER is folded in such a way that it doesn't bind to our endocrine therapies very well, maybe slightly partially to some of the fulvestrant will bind to some of the ESR1 mutations, but for other ESR mutations, not at all. But it's just partial, and it's just constitutively active. And when you've got the ESR1 mutations, you've got activation of ER in the absence of estrogen, as I said. You've got decreased binding to estrogen, tamoxifen, and SERDs. The estrogen receptor becomes more proteolytically stable, more difficult to destroy through the proteasomal system. It drives proliferation, survival, migration, metastasis, and really complete AI resistance. So these are very, very important, but the cancer is still being driven by the estrogen receptor. But what's shown here is, when do you expect to find these in the metastatic setting? And the answer is 0 in your primary breast cancer. But when patients first recur and they first develop metastatic disease, and you biopsy it and you sequence it and you get ctDNA at that time, it's only maybe 5 to 10% of the time you'll find an ESR1 mutation. But then after progression on first line therapy, particularly AI plus CDK, you'll find it 33% of the time, it shoots way up. And then by the time they finish their second endocrine therapy and you check it again, now you're going to find it 40 to 50% of the time. So it's really common. And the oral SERDs are really excellent therapies. And so we want to find that alteration so patients can become candidates for the oral SERDs. Now, the ESR1 mutations do not exist in a vacuum, right? These cancers can have co-mutations. They can be co-mutated with PIK3CA, not uncommonly. They can be co-mutated with AKT, PTEN. And how often does that really occur? And you can see over on the left in the first line setting, first line metastatic breast cancer, co-alterations, co-mutations in ESR1 and PIK3CA uncommon, like 4%. After progression on first line therapy, about 8%, and then about 17% after progression on second line therapy. So we do find these co-mutations, quite frequently, actually. And I just want to stop here for a second and just ask Dr. Bardia Aditya, does that sound about right to you in terms of your personal experience in the clinic? Is it really quite uncommon in the first line setting?
That is exactly correct because ESR1 mutations are acquired mutations after and aromatase inhibitors. So generally, we don't see much in the first line setting, but in the second and third line setting, you see the frequency increase. And series have shown that up to 50% of patients can have detectable ESR1 mutations with serial testing. And I think that's the key point to do a testing serially and to use plasma based genotyping.
And why plasma based testing?
I think for a couple of reasons. One, it's more convenient for the patient to do a blood draw as opposed to do a new biopsy. And because these are acquired alterations, if you test primary breast cancer, you're likely going to miss it. You need to look at the current status. And second, it also addresses spatial heterogeneity. If a patient has multiple lesions, there might be some lesions that have the mutations, others that don't. But in plasma, you have a summation so potentially can be more sensitive in terms of detecting these mutations.
Super. Thank you. Thank you. And just one more question, if I could. I know we're going to talk, kind of high level data, big picture data. But when you have a patient who has both an ESR1 and PIK3CA mutation, let's say she's already had her AI plus CDK first line, and now she's progressed, and you find dual mutations. How do you decide, Adi, which one to target first? And we may end up targeting them sequentially because we don't have FDA approval yet of a combination that inhibits both PIK3CA as well as the ESR1. How do you decide what one to start with?
That's a great question. That's where I look at the prior duration of CDK4/6 inhibitor, which we generally use in the first line setting. The subgroup analysis from Emerald showed that if a patient has been on prior CDK4/6 for more than 12 months, in that setting, the tumor is still more ER dependent. And if you're seeing ESR1 mutation, you can consider elacestrant. The activity is maintained. But if a patient has more rapid disease progression on first line CDK4/6, that's a setting where I would preferentially start with combination therapy or even consider ADCs.
So our we haven't really had a big, huge advance in endocrine therapy for decades before we've had approval of the oral SERD elacestrant. Of course, we've had aromatase inhibitors, I think, for the metastatic setting since about 1996 or so. The problem with aromatase inhibitors is that they really do lead to the acquisition not only of ESR1 mutations, but of a whole host of other mutations as the cancer cells, work to get around estrogen deprivation. And there's also toxicity of the aromatase inhibitors, which of course we're very well familiar with. But in the metastatic setting, that doesn't tend to be too much of an issue. It's more of the acquisition of resistance to the aromatase inhibitors in the metastatic setting. Tamoxifen is only a partial ER agonist. As we know, there's still activation of one of the co-activators, the AF1. So it is a weaker inhibitor of the estrogen receptor because it's a partial agonist, partial antagonist. It too has toxicities. Again, not a big issue in the metastatic setting. It's really more the activity. And then lastly, fulvestrant. Now, fulvestrant really does destroy that estrogen receptor. The big issue with fulvestrant is that the pharmacokinetics of the fulvestrant, you really can't get the maximum effective levels of the fulvestrant. We can't give any more than two of the 250 milligram IM injections. It's just too much to ask a patient to have three. But ideally, in terms of the optimal level of fulvestrant to destroy the estrogen receptor. I remember the early phase 1 trials and getting up to 750 was really potentially maximally optimal in terms of effectiveness, but we just can't do it. So 500 may not be for some patients the optimal dose of the fulvestrant. So it's just hard to get it into the patients. So it can lead to incomplete degradation. After patients' breast cancer progresses on CDK4/6 inhibitors, fulvestrant, as we'll see, has very, very limited activity as a single agent and very, very limited activity in ESR1 mutations, particularly one of the most common ones, the Y537S. So, we definitely were due for a breakthrough, another advance in endocrine therapy, and the oral SERDs are providing that for us. So several advantages. Oral is great. Of course, fulvestrant, another limitation is the intramuscular injections, higher potency than fulvestrant because the oral bioavailability of these is very, very good. And you can get up to the dose that really can lead to the complete destruction of the estrogen receptor. They're highly active, as we'll see, against these ESR1 mutants, and they're active as well against wild type estrogen receptors. They're equally effective as fulvestrant. They absolutely work against the wild type, but they got a large differential benefit of activity compared to fulvestrant in the ESR1 mutant population. And as you'll see, there's a lot of data that they're active after patients' breast cancers progress through an AI plus CDK4/6 inhibitor. Well, you can see there's quite a long list here of agents that are in development targeting the estrogen receptor. We're going to focus on those that really have provided us with phase 3 data. Stay tuned. There's a lot more coming, but we're going to talk about elacestrant and camizestrant and imlunestrant and also vepdegestrant. We're going to talk about 4 that we have phase 3 data because that's really quite a lot. More phase 3 data are coming, however. So, oral SERDs, what did the data tell us? I'm going to turn us over to Aditya because he's really been instrumental in a number of these trials. But the key things we think about as a patient journeys through metastatic breast cancer is we need to understand when the person's disease first recurs, how likely is this cancer endocrine therapy sensitive? And we have to ask ourselves that question every time that cancer progresses through her the therapy that she is on. We do have to do some occasional biopsies because unfortunately, these cancers can lose the estrogen receptor altogether, and that becomes a totally different biology. We have to constantly monitor for drivers that we can target that really are responsible for endocrine therapy resistance, and those markers usually as well can also guide us as to which targeted therapies to choose. So those are some of the key considerations we think about every day for individual patients as we think about how to sequence their therapy. So at this point, I'd love to turn us over to Aditya to just give us kind of like a high level overview of some of the key phase 3 data that we have available.
Yeah, absolutely. Thank you for nicely reviewing endocrine therapy, resistance, ESR1 mutations. So this slide, this essentially summarizes the key studies related to elacestrant as well as with imlunestrant and then camizestrant as well. And what you can see is essentially the outcomes are very similar across these oral SERDs. in patients with ESR1 mutations, we could see benefit in terms of median progression free survival over standard of care endocrine therapy. And if you look at additional analyses, we can see that in all of these trials, there was a subgroup of patients who did not derive benefit from endocrine therapy, patients who have more endocrine resistant disease. So there's this initial drop in the curves from all these studies. So the next question was clinically, can we identify a subgroup of patients who would have this drop? And that's where the prior duration of CDK4/6 inhibitor can be helpful. Subgroup analysis from Emerald showed that patients who have this prior duration of CDK4/6 inhibitor for at least 12 months, that's a subgroup where you see benefit with single agent elacestrant versus standard of care endocrine therapy with results that are clinically meaningful, a median PFS of 8.6 months. So some of us do consider this as a clinical biomarker for selecting single agent oral SERD in the second line setting. Now, the other thing to consider is combination therapy. We saw from EMBER 3, which looked at imlunestrant plus abemaciclib, that combination of imlunestrant plus abema was superior to imlunestrant as a single agent. So it does appear that combination therapy is superior, but then combination therapy can also result in additional toxicity like diarrhea. So like to hear from Joyce, as we have multiple drugs approved in the future, elacestrant is currently approved, but there will be other agents likely that will be coming in. And then we also have combination data. How would we select between these drugs and your thoughts on combination therapy?
Well, I think, DJ, at the end of the day, when the patients are progressing on first line AI plus CDK, that um, if we have options that we're going to want to use combination therapy whenever we can. For example, if someone's got dual mutations in ESR1 and PIK3CA or AKT or PTEN loss, we want to inhibit both the PI3 kinase pathway and an ESR1 mutation. If we look here, for example, at the combination of imlunestrant plus abemaciclib, we're getting into median PFSs of 9 to 11 months, and those are obviously longer than single agent, even oral SERDs, as we'll discuss. Now, having said that, as you said, there's more toxicity with combinations. And so there are patients, and you showed that with the Emerald study and the elacestrant, there are patients who do very well. They'll get a median of 8.6 months, which means half go longer with single agent oral SERD. And I think from a clinical perspective, those are generally patients with more very, very endocrine therapy sensitive disease, bone only. They don't have rapidly progressing liver disease. The patients we think of where we're pretty confident they're likely to benefit from another line of endocrine therapy. So, the I think that there's room for both strategies, single agent as well as combination therapy. But I think we're looking forward to the day that we do have combination therapies to offer some of the patients.
No, I very much agree as well. And then the other points, I would make, we can move on in terms of AEs, that as we have these multiple agents, one important consideration would be the adverse effect profile. Elacestrant tends to cause more nausea, imlunestrant, more diarrhea. With camizestrant, we are seeing bradycardia and visual side effects. So the AE profiles might be helpful in terms of selecting these AEs. We've seen that the type of mutation does not matter in terms of the type of ESR1 mutation. Even patients who have double mutants, as you were discussing, we can consider these agents. So it'll likely be the AE profile.
What about the this slide here, Aditya, from the Emerald trial, which looks at co-mutations with ESR1 and PIK3CA, P53? What's some of your take-home messages from the work you've done looking at co-mutant?
I think that's an important analysis done from the Emerald study. The Emerald study showed that patients who have ESR1 mutation plus PIK3CA or AKT or TP53, as long as the prior duration of CDK4/6 inhibitor was more than 12 months, the benefit with elacestrant was maintained. So I do find that helpful as a clinical biomarker.
Gotcha. Awesome. Awesome. Thank you. I just want to mention, you've already mentioned the combination of the imlunestrant and the abemaciclib here. And this just shows with the EMBER-3 with the prior CDK4/6 inhibitor and in patients with PI3 kinase mutations that um, it did not make any difference whether those mutations were there or not. The combination of the imlunestrant and abemaciclib was equally effective regardless of ESR1 mutation status, regardless of PIK3C mutation status, and regardless of prior CDK4/6 inhibitor. And there's also an interim survival advantage. And so, just for the sake of time, I just want to show you the oral PROTAC data as well. And you can see with the vepdegestrant as a single agent compared to fulvestrant in the VERITAC-2 trial post CDK4/6, we see this very, very nice improvement in PFS in the ESR1 mutant population. And likewise, as we've already shown, camizestrant as well, very much more effective than fulvestrant in the ESR1 mutation patient. And then the very interesting data from Serena-6 showing that switching in patients who are on AI plus CDK first line, if they develop an ESR1 mutation but they haven't progressed yet, that switching over to camizestrant and continuing their CDK4/6 inhibitor can really substantially improve progression-free survival, as we see here. So thank you very much for joining in, and thank you so much for participating in this event.